Thank you for joining us today for our TIF Talk Physician Edition. We've got some very special guests with us today. Dr. Glenn Ihde, he is a general surgeon at Matagorda Regional Hospital in Bay City, Texas. He also recently published a new review article in Therapeutic Advances in Gastroenterology, The Evolution of TIF. So thank you so much, Dr. Ihde, for being here with us today.
Thanks for having me.
You're welcome. And in addition to that, we have Dr. Jonathan Schneider. He is an advanced endoscopist at the First Clinic, part of TriStar Medical Group in Nashville, Tennessee. He performs procedures at HCA's flagship hospital, Centennial Medical Center. Thank you so much for being here today, Dr. Schneider. So we're very excited to have this presentation today. I do want to let you guys know that we will be taking questions and answering them during and after. We'll have a Q&A session at the end of the presentation. So please feel free to ask any questions that you may have. There is a Q&A button at the bottom of the Zoom call, and you can ask your questions there, and we'll go ahead and try and answer them as best as we can. As you all know, our TIF Talks are really, the goal for these TIF Talks are to foster communication around topics that are relevant in today's world. So I'm very excited to have Dr. Ihde talk about his recent paper, The Evolution of TIF, and then also Dr. Schneider to give us a GI perspective of starting a GERD program with the TIF procedure. So we're going to go ahead and start off with Dr. Schneider. Do you want to go ahead and share your slides?
Thank you, Integrastic Solutions, for the invitation to talk. So obviously this is going to be from a GI perspective, me being a gastroenterologist, and really kind of briefly go over some basic GERD, LPR kind of symptoms, but focus on patient selection for the TIF procedure and how I built, starting a couple of years ago, a TIF program, and how I work with surgeons for patients that need a concomitant hernia repair. So starting with, probably the most basic of basic slides for the crowd here, but really just to show that there's been a development in the kind of the symptomatology recognition over the years. And I've finished fellowship about 8 years ago, and I've seen it just in the past 8 years, going from the classic heartburn, chest pain, typical symptoms to a lot more recognition of atypical GERD symptoms. They've obviously been there the whole time, but I think we're getting a little more in tune with what GERD can do as a disease. I'm seeing a lot more referrals from other specialties. So it's become a multi-specialty disease, from pulmonary doctors for dry cough, aspiration issues, sleep issues, ENT for hoarseness. I'm seeing referrals from dentists for dental issues. And just to point out, about a third of people with the atypical GERD symptoms you see on the right side of the screen really have no typical symptoms. So they don't present with heartburn or chest pain. So I think it's really important for us to kind of educate other specialties in the recognition of the disease. So my patients worry about the things on the left, the kind of typical symptoms. I really worry about the things on the right and preventing those. And studies have shown that this can progress kind of left to right asymptomatically with people on PPI. I do endoscopic ultrasound, so I do a lot of cancer staging in the esophagus, do FRA, so do a lot of ablation for Barrett's. And we see people that come, stricture after stricture, and it gets more frequent. We're dilating, it gets tighter. Then we're talking about stenting for benign disease, where we'll follow up a non-dysplastic Barrett's patient 3 years later. They have adenocarcinoma in the esophagus, and we all know that's the fastest growing cancer in the US over the past several years. So it's really trying to catch these patients early to stop the disease, with a safe and durable procedure to prevent all this complicated GERD patients you see on the right. And we all know an esophagectomy is very morbid and mortal procedure, and their lifestyle after this is seriously diminished. So I think patients are getting a little more in tune with side effects of PPI. I remember sitting on my back porch a few years ago, and the nightly news and the leadoff story was dementia and PPIs. And texting my nurse and say, get ready for some phone calls tomorrow. And sure enough, they came. So people are a little more aware of what PPIs can do long-term. That dementia paper came out a few years ago, and it's a huge cohort study from Germany, but other studies since that time have really shown a strong association, certainly not a causation. We've known about osteoporosis. The women know this. We know about increased C. diff. Recent papers with increased incidence of microscopic colitis, not listed here, but that's thought to be true. And maybe the latest, greatest is kidney disease, chronic kidney disease, definitely, and there's acute interstitial nephritis issues. The hospital I work at has 4 or 5 screens we have to go through just to order a PPI. So, I think we're in tune that these medicines, while rarely causing acute issues, can definitely lead to complications with long-term use. So when I see a GERD patient in my office, I always kind of back up and do an anatomy lesson with them. I draw a picture. I say, this is your esophagus. This is your sphincter muscle, that little circular muscle at the end of your esophagus. And they, what they invariably call the flapper, the valve. I say, this is where your stomach is. And then we draw out a Ihde hernia. This is your diaphragm, your breathing muscle. Separate your chest from your abdomen. This is what a Ihde hernia looks like when your stomach slips up. And I say, you can take Dexlan all day or Nexium all day, but stomach contents are still coming up. They may not be acidic on your acid blocker, but they're still coming up. And there's plenty of other non-acidic contents that when come up to your esophagus or even higher, cause lots of problems. And you can see the light bulb go off in their head and they'll say, oh, so this medicine is not a fix. It's not curing reflux. It's just preventing some issues. How do we actually get this back to normal? And that's when we bring up anti-reflux procedures. And I say, this is a mechanical problem. So you need a mechanical fix. And this is a function problem of your LAS. So we need to improve the function of that and restore your anatomy to what it was 20 years ago before you started having symptoms. So what we want as a doctor on the left side is, we want everybody's symptoms to go away, improve quality of life. If we do a follow-up pH analysis, we want it to normalize. We don't want your uncomplicated GERD to become complicated with strictures and Barrett's and RFA and surgery. When I ask patients what do they want, they obviously want something safe. They almost all say, because of media, I want to be off the pills. I don't want to take them anymore. And one of the most common desires from a patient I hear is like, I just want to be able to sleep at night and sleep flat. The number of patients that are sleeping in recliners is just amazing when patients tell me this. I fortunately have rarely had reflux. I've had it a couple of times, usually at night if I eat late or exercise late, and it comes up, it wakes you up, you have trouble breathing, it's very painful. And you think you can just drink water, lay down, go away, but it lasts for hours. And these patients are dealing with it night in, night out, sometimes for years. So this is probably the most important slide of my talk. And starting on the left, I still consider myself a less is more doctor. And I always talk about lifestyle changes. I think it's mandatory that we do this. And if someone can lose 15, 20 pounds or stop, half pack a day habit to nothing, I tell them their GERD will get better. Now, if it's a 400-pound chain smoker, that it's a different talk. Bariatric surgery, gastric bypass may be the option for them. If we can get you off a PRN Nexium to a Tagamet as needed with a little bit of weight loss, that's what we encourage. But for a huge majority of my patients, they can't. They've tried the lifestyle, it's not working. They try to get off the PPI, it's not working. So there's this huge demographic of my population that are stuck on the PPI. They try to get off, they can't. Getting lifestyle measures aren't working. And we get in this habit of just refilling their PPI every 6 months or 12 months. And I say, do you have any dysphagia, weight loss, melena, anemia? And they say no. And I said, all right, well, no kind of red flag symptoms. So here's your PPI. We're just giving these things away like Oprah's giving away gifts. And now the TIF came along, and for me, it opened up something we can do earlier on, intervene earlier on, instead of waiting for that 2-centimeter hernia to become 5 centimeters and the non-dysplastic Barrett's to become cancer. And I think of the TIF procedures as something else in the arsenal. I don't push it on people. It's not for everyone. But for the large, I would say that large majority of my patients, it's been perfect. And it's the ones we're just trying to get off the PPI. They want to get the PPI. We'll do it when there's no hernia or when it's 1, 2, 3 centimeters. instead of waiting until it's too late. So once I decided, after reviewing all the numbers, and I talked to a couple other doctors who did the TIF procedure, and they said it worked great, it's safe and durable, I needed to develop a program kind of from the ground up. And so I would say when I started, I would do TIF alone maybe 20% of the time, and now it's maybe 10% of the time. Once you realize that almost all these patients have hernias, and some of them pretty big, obviously needed a surgeon to work with. So that's probably my number one point is, you need a good working relationship with a surgeon. I approached, who I think is a fantastic surgeon, Trudy Goers, who's a fellowship trained in minimally invasive GI, who does Nissens and does links. And she had read up on the TIF too, and we just met after work one day, and I said, look, I think we should do this. I think it's a great opportunity for us and our patients. It's just something else we can offer our patients kind of earlier on. And she was agreeable and said, let's just do a trial of 6 to 9 months and see how things go. And we've had excellent outcomes, both been happy. Our patients are very happy. So that, we're been doing about 2 years now. When I first started to try to get the word out, I sent mailers to my patients. And even if you don't wind up doing the TIF procedure, don't have much interest in it, I would encourage you to ask your front desk staff just to give you a list of patients with ICD codes like GERD, esophagitis, stricture, Barrett's. So me and my partners, just 5 of them, so 6 of us, I asked my front desk to do this just for unique individuals for the past 2 years, and I excluded anyone over the age of 80. I think we had 1,200 something different patients who we had seen over the past couple of years for those diagnoses. And we sent them a letter just saying, we've identified you as a GERD patient. We have this new procedure, works well. Do you want to come in and talk? And this is when my daughters were 8 and 10, and they can bribe with small amounts of money. So I paid them a nickel to stuff the letters. They knocked it out in 1 week, and we mailed them kind of bulk of 100, so we didn't get 1,000 phone calls for my nurse. But they started coming in. They're very interested. So that really ramped things off right off the bat. And then I set up a kind of a casual discussion, nothing formal, with a bunch of internists I called personally or texted personally, and I've been in a room at a restaurant and they say, come by for a beer, have an hors d'oeuvre. We got this new procedure, had the device there, told them how it worked. And it really kind of ramped up from there. And there was about 15 and 20 internists who came for that. And then EGS also offered direct-to-consumer advertising, which at first I was a little skeptical of, but it's worked out perfectly. They're targeting people who are looking up ways to get off their PPI or ways to help their GERD symptoms. And I've been told 2 to 3 in the morning can be a peak time. So it's these people sitting up, being woken up from reflux, getting tired of it. And since Big Brother's always watching, they can kind of target these individuals, throw an ad at them on social media. They fill out something, a nurse calls them, and they're transferred directly to my front desk. And I've agreed to kind of see them within a couple of weeks. So also a big concern is how are we actually physically going to do these combo days? Certainly if it's a TIF alone, I just kind of block an hour for the whole procedure, including intubation and waking up. But when I've worked with surgeons in the past and say, hey, I'm going to need you at 10:30, it usually turned out to be noon. And we just couldn't do that if you're trying to do 10 procedures in the morning and start clinic at 1. So we kind of pick a day a month. Sometimes if we're busy, we have 2 a month, and we have 2 operating rooms right next to each other. So we flip-flop back and forth. And Dr. Goers would start usually about 7:30. It's usually 30 to 45 minutes per hernia repair. Obviously, it depends on the size. I like to be there to pass the bougie if I can, or at least see the nurse anesthetist pass it. The device is 60 French, so it's pretty big. Obviously, anybody with a tight stricture, I've already excluded. I'm not even gonna think about doing this to them. Just to get a sense of how tight it is, and also to open up the oropharynx. I usually do a couple of procedures starting at 7, come in at 8, and I usually watch Dr. Goers. I worked with a thoracic surgeon this morning, actually on one, Dr. Gilmore. And it takes me about 20 minutes. That's a scope in. I kind of measure where the G junction is, make sure the esophagus looks fine. Do the procedure, which is about 15 minutes by itself, again, pretty quick. And then a follow-up EGD, just be sure the esophagus looks okay. Patients love the pre and post-op pictures. A picture speaks 1,000 words, so it makes sense of what we're doing once they see it. And we've done 2 or 3 a day. We've done 6 a day a couple times. So it's not not a long day. I mean, we can do 5 combos in 6 hours, and we usually try to go out for a beer and celebrate the eradication of GERD in those patients and take our staff out as well. They stay 1 night in the hospital, just under a 23-hour OBS status. We see them the next morning, half are in street clothes, ready to go. They follow up with me. We try to make it simple on the patient, so they just follow up with me, not necessarily the surgeon. You have to drive for a second procedure. And then, a reasonable question is, what about billing and reimbursement? The CPT for the combo is 432A1 with a 62A modifier, so 2 surgeon or co-surgeon modifier. And it works perfectly. It's been covered. We've had no issues with that. For TIF alone, the code's 43210, pretty easy to remember there. Medicare covers it. We get prior authorization for commercial insurance, and I would say at least 80% have been covering it. So it's not been a big issue for me. This is my last slide here. I mean, I'm thinking about keys to a successful program. I think we did my 95th this morning. I have a few more tomorrow. Obviously, he's a good surgeon and a good working relationship. We're all probably have the GI and PCP referrals in place, but I think reaching out to these subspecialties have been really helpful. The ENT doctors, the ER. I've walked to the ER and said, hey, all these guys you sent home with the GI cocktail or PPI, we can see those people. We can help those people. And all the cardiology consults we get for non-cardiac chest pain, I'm like, yeah, we can see those. It may be GERD related. Again, ability to see in the office soon. If they call my front desk on June 24th, and my scheduler says, all right, September 24th, 1 p.m., they're not going to show up. So I've told the front desk they can just be worked in within a couple of weeks. As far as testing, almost everyone gets an EGD for me or my partner, along with pH testing, and the overall pretty quick procedures. So I said we can work those in as well. I try to make it easy on the patient. I've called Dr. Goers and said, hey, I got this lady here just following up her pH stuff. I think she'd be a great candidate, and she'll offer to say, have him walk over. I'll see him right now. So trying to make it easy on the patient. And the feedback to the referring providers, I know we all do this anyway, just to stay in business, but it's very surprising. I mean, very few primary care doctors that referred to me before TIF had ever heard of it. So I make a point of calling them after my 4-week follow-up, if I have their cell phone, or texted them or calling them and just saying, hey, I saw Mr. Jones. He's doing great. He's off his PPI, doesn't have any GERD. Thanks. And they love hearing about it. So we're kind of spreading the word among Nashville, I feel. And that's obviously happy to take questions after Dr. Ihde's talk, but those are my slides.
Fantastic. Thank you so much, Dr. Schneider. We really appreciate that. I do have one question, or maybe a couple of questions. So I think you mentioned that you had your 95th case just today. You're almost reaching that 100. And I know, I remember when you started, you started from the pretty early on and ramped up pretty quickly. What do you attribute that success of ramping up that kind of TIF procedure volume for you?
Well, I mean, having a big, busy practice with 6 of us in the first clinic helped. The mailers were probably, honestly, what really ramped it up pretty quickly. And now I'm to the point where primary care doctors are sending new patients back saying, hey, Dr. Schneider helped me on a few other patients. I'm going to send you over there. And again, the dinner helped as well, just kind of getting ramped up. I saw a patient today who's interested in it, and it was just referred by a friend. So, the past year or so, it's been a lot of word of mouth saying, hey, you have my friend, I'm my candidate for this. Fantastic.
One other question. How many additional cases do you believe you do as a result of partnering with Dr. Trudy Goers?
Myself, I mean, it's been obviously a lot more upper endoscopies for me, along with pH testing. Of the 95, I would say maybe 75 have been combined. So that's probably 75. I worked with a thoracic surgeon a few times, but she's probably had 70 additional surgeries over the past 2 years that she might not otherwise have had.
Wow, that's fantastic. Thank you so much for sharing your story. And we're going to go ahead and pass it on to Dr. Ihde.
All right, thank you, Andrea.
You're welcome.
And thank you to EGS for asking me to participate in today's TIF talk. I've been at this for a little while and have had the opportunity to participate in some of the research and have known many of the people in the company for years and years. And so we got to talking about, you know, if we were going to publish a paper on like what has happened today, how we got to where we are. And in particular, we wanted to emphasize that, you know, there's been changes in the device, but there's also changes in technique. And one of the problems that we were having is that there were articles that were comparing an older technique and an older device with the newer technique and the newer device. And it was confounding sort of the discussion during conferences and those sorts of things. And so we put together this paper. I had a lot of help from the EGS people in terms of, you know, the device changes, and I really appreciate their help. And then from our side, talking about, you know, the different techniques and the way those were modified, gave us a chance to review quite a few papers. So I'd like to just kind of go through some of those things, also validate the safety that we've seen over the last 10 years, and understand that this has been kind of traveling a previous road in which the principles of reflux surgery were established at the time of the heydays of laparoscopic NISPs, using a new device and a new technique. So this is sort of a loaded slide in which EGS only gets one slide for their years and years of device innovation. It started off really with a device that was hand-loaded, single fastener delivery on levers that you would slide out. The Esophax 2 was really a cartridge design that made it a lot easier, but there were still quite a few advances in that design, including going to a bigger lumen so you could use the newer HD devices, creating a window so that you could see the loading of the stylets, creating a dome that covered the stylets as they came out. And that really became the Esophax Z device. And they also improved things like clamp force. So when we created the fundoplication, sometimes that would slip out of the device as we were trying to advance the Z line. Also, they improved the hinge strength so that the tissue mold would line up with the chassis directly every time. And then, you know, the Z Plus was really what we use today. It really worked on the delivery mechanics, so it automated the delivery mechanics, and in my opinion, gives us a very, very uniform and reproducible fundoplication every single time. Kind of the rest of my talk then is about the technique evolution, because that's what I was involved in. And, you know, when we first started out, we were already in 2009, we got this kind of slide that talked about ELF. And what was ELF? Well, it was, the original concept was to create a gastrogastric fundoplication that would be bulky enough to block the hiatus so you wouldn't get a herniation. And they did about 186 cases and then moved to a fundoplication on the gastroesophageal margin, and that was about 2007. And the development from that changed fairly quickly. There was a transition to a approximately 2 centimeter to 4 centimeter fundoplication onto the esophagus, which was called TIF 1. And that really brought it to the United States. There were 673 cases, but it pretty rapidly turned into TIF 2.0, which is the rotational technique that was described by Reg Bell. That was in 2009. Pretty quickly in 2009, we were immediately using TIF 2.0. This is the technique that's been done since then, over 20,000 cases. It's really the only valid technique in literature. So you have to be careful as you go through literature and you're looking at the historic literature that you identify the technique. Anything before really 2009, 2010, you have to be careful that you're talking about the TIF 2.0 technique. So the next technique evolution was we were looking at these patients in pre-op endoscopy, but also at the time of TIF, and saying, well, you know, that hiatus looks pretty big. You know, is this going to stay below the diaphragm? And that ended up not being the case, as we showed in this study, in which we took and compared our TIF-only cases to a TIF with crural closure, and identified there was, you know, pretty significant improvement in the outcomes. Yeah, even though we did get improvement, there was still some margin to improve. So then we began to ask ourselves, okay, well, how big does a hiatus have to be? If you look at the Hill criteria, and over here on your left, you see what normal is, and then grades 1 through 4, kind of a progression really of dilation, loss of the angle hiss, and then dilation of the hiatus. So where in that exactly do you do a repair? And there was indeed some confusion with that. And we started looking at the different decision points. So, and if we say, you know, we're going to repair Hill 2s or Hill 3s, but not Hill 2s, is that going to work? And when we looked at that, it didn't. We were all calling a Hill 2 half the time something else, either a Hill 1 or a Hill 3 or sometimes a Hill 4. And so pretty early on, we decided that that wasn't going to be what we could use as the common language. Then we even looked at, okay, well, what is the situation in which we're doing the evaluation? We found out whether you do it by IV propofol versus general anesthesia and paralytics makes a difference. And then also we started comparing what we saw laparoscopically to what we saw endoscopically, and said, well, you know, is this the same thing? Are we missing something? Indeed, that, you know, there might be, you know, a 10%, which of course is going to end up being a ineffective TIF. So all those things eventually came to this. So we've decided that we needed a standardized measurement, and there was not a way to do that. If you try to use video optics, there's always some distortion to that, either from distance or angle. So what could we use? And so one day I sat down and measured the endoscope. I said, well, if I use the end of the endoscope, I know it's at least 3 centimeters across, and I can use that to compare the hiatus and say, well, is this something that needs to be repaired or not? And the omega loop of the endoscope is 4 centimeters. So there's some technique to we go to, you know, the 12 o'clock position is what we talk about. We sort of rotate back and forth. We try to insufflate, and we see if the tip of that scope will fit in there. And it's not something that we, you know, put a lot of tension on the scope or anything like that. But you can tell that when you rotate to that 12 o'clock position, that scope tends to push forward on the anterior aspect of the GE junction, and that opens that hiatus up for measurement. And so we decided then to look at the patients that we had done over a year period of time and say, well, they've validated. In particular, we were doing pH studies both before and after repair. And so we started out with 97 patients. About 55 of them ended up having surgery. Because this was a retrospective study, not all of them had pH, not all of them filled out their surveys, but we ended up with 29 patients that we could compare preoperatively and postoperatively. And we found that of those patients, 72% of them normalized their pH, which was pretty good. The overall pH score improved to normal, but if you looked at the individual patients, 72% of them normalized. But then we went a little bit further and we said, well, you know, let's contact these folks and bring them back and see if we can understand why the PH is abnormal. And as it turned out, several of them had recurrent hiatal hernia with further study, and one didn't follow up. So if you look at this, okay, well, are we judging patients in which our repair is intact? 95% of those patients had a normalized pH. And if their anatomy is not intact, then of course, we don't expect to have control of acidification of the esophagus. And pretty much that's what's borne out in the study. And it's retrospective. It's a small study, but fortunately, we're now involved in a prospective study along the same lines. So that's where our current technique is. In terms of safety, we were also able to put this together and put this into the paper. And we look back at all of the reported injuries or complaints. Even and say, okay, well, our cases where most of our problems occurred, serious adverse events, and that they've decreased in time, both with development of the technique, but also with development of the device, because you have to remember that before the stylets were exposed and now they're covered, and we have a more automated way of placing the fastener. So it's, in my mind, a much safer device. I think that's borne out statistically. Even the device, the way you load the device on the endoscope has changed so that it's a true overtube now instead of being just banded on there. So if we look at kind of the studies that have been done, we can show that, you know, our effectiveness has improved over the last 10 years from, you know, 70% to 90%. We have pH scores now that validate what we think we're seeing and what we're getting on subjective surveys. We can see that the safety rate is markedly improved over laparoscopic fundoplication. And it's 10-year outcomes, quite a few 3 to 5 year outcomes and 10-year outcomes that show that this is a durable repair. Sort of the problem is the hiatus and its repair, and people are still trying to come up with better techniques to improve that part of the repair. But, you know, transoral fundoplication, transoral incisionless fundoplication are widely accepted. Most insurances cover it, Blue Cross Blue Shield, of course, Medicare, and the society. So at this point, if we look over the history of TIF and the addition of hiatal hernia repair, we've reestablished these principles that were really identified in the 1990s when we were moving out of open fundoplication to laparoscopic fundoplication, which is I finished my training in a lot of studies. That's obviously how my attention got turned to this. But, you know, the principles are that, you know, we have to have the fundoplication on the esophagus. You got to construct it without a stricture. And since we have a 60 French device, we're able to do that. Fundoplication 2 to 4 centimeters. Our tissue mold aligns that so that we get 2 to 4 centimeters. Fundoplication has to be below the diaphragm. And of course, now we have the instructions for use that allow us to talk about repairing the diaphragmatic hiatus just before we do the TIF. And I think that that's really what the future holds. A few years ago, I started talking about TIF and hiatal hernia, with TIF being the new anti-reflux standard that we should care for reflux surgery. And that's because we have a superior safety profile. We have equivalent disease control according to the studies. But mainly the reason we quit doing this was because of the side effect profile, the bloating, gassiness, dysphagia. And this has been negatively correlated in Tempo Level 1B studies. So it's clear that we have a better procedure in terms of reducing the side effects. And we have durability trials now as well. So in my mind, like Dr. Schneider said, when somebody comes in on PPI therapy, we really have to look at if that's the best thing for them. Give them an adequate trial, but I think 6 months is probably an adequate trial. If you're on PPIs for 6 months and you're continuums where you can't get off the PPIs, guess what? That's probably an anatomic defect, and covering that with a chemical Band-Aid is not going to cure the disease. And we need to look at the safety profile, the side effect profile, the cancer profile, and decide that maybe at 6 months it's time to move on. And that's pretty much my presentation. So I think be happy to take questions, Dr. Schneider as well, if people want to throw them out, or field them from Andrea or
Yep.
Christian.
Fantastic. Thank you so much, Dr. Ihde. We appreciate that. We actually got quite a few questions that came in, both for yourself and for Dr. Schneider. So if you don't mind, I'm going to go ahead and start asking you questions that we've received thus far. So first question, this one's for you, Dr. Schneider. Does the surgeon do the TIF as well? So they're basically asking if the surgeon that you partner with does the TIF procedure. You're on mute too, sorry. Might want to unmute yourself. There you go.
A reminder. She does not. And the thoracic surgeon, I've done a smaller amount. They do not do the TIF procedure. So she's does links and Nissens.
Okay. Thank you. Another question for you, Dr. Schneider. You previously mentioned how you've reached out to ENTs about your reflux program. How did you go about that, and what are your thoughts on how the referrals have impacted your practice?
You know, I did it very informally. I think the physician's lounge at our hospital's a great place for this to occur. I mean, sitting across from ENTs and cards and ear doctors for breakfast and lunch. So it's been a lot of casual things like that. I actually gave my card and some brochures to my dentist, who has sent me patients. I didn't think I'd ever be doing TIFs on referrals from dentists, but we have. So a lot of it's just been, I think, word of mouth at this point from partners. But I plan on doing another kind of casual happy hour dinner, probably with other specialties besides just internists. Okay,
fantastic. This could be probably for the both of you. The CPT shown, I assume, is the one we as GIs will submit. If so, what is the average reimbursement for professional fee, and are you aware of RVU equivalents?
Do you want to start, Dr. Ihde?
Yeah, so it was interesting as this came through the CPT committee. They did an interesting thing, is that they have, that's the code you use, and they have a reimbursement for doing the TIF alone. But then if you do a combined procedure, instead of doing a 50-50 split of it, you actually get, I forget what it was, 70% of the fee for each side. So actually everybody does pretty well for it. I don't know what the exact fee or RVU is, but it should be equivalent no matter who's doing it. The surgeon doing the hiatal hernia repair can report the hiatal hernia repair with the 62, and then the gastroenterologist is also reporting 43281 code is a code of how to repair with or without fundoplication. And so when you do the fundoplication, you still listed under that code.
What was that code again, Dr. Ihde? You kind of cut out a little bit. I just want to make sure all of the people watching could hear that code.
Yeah, the hiatal hernia repair with fundoplication is 43281. Perfect.
Thank you. And Dr. Schneider, did you want to add to his answer? Or
yeah, it's just a few emails at the beginning a couple of years ago for this code to work. Just a little bit of text I needed to put in my body of my note that I was a co-surgeon. Patient was sedated. I proceeded, under the same sedation to do the fundoplication transorally. But yeah, it's just, we both use the same code with the same modifier.
Perfect, thank you. Dr. Schneider, this one's for you. Any tips on making sure the coders for the hospital and both offices are on the same page?
This was also worked out pretty quickly just via emails and text right at the beginning. And Dr. Goer's schedule and my schedule both have each other's cell phones, so it's very easy to communicate and get people boarded.
Okay, fantastic. Let's see, this could be for either of you. What size hernia would you consider too large for TIF and hernia repair?
So I think that after you repair the hiatal hernia, you can do a TIF on any of these, because there isn't any data that shows doing a Nissen or Gore or toupee improves your hiatus repair or the durability of your hiatal repair. So, I've been asked that question a lot, and I think that initially people are thinking, well, you're in there laparoscopically and just get it done, but it still doesn't make any sense from the standpoint of the side effect profile and the safety profile. Repair the hiatus when it's down to a normal size, then you should be able to do the TIF.
Perfect. Anything to add, Dr. Schneider?
No, I agree. I mean, I've seen really big hernias to Dr. Goers. And I got the same question initially saying, well, if the hernia's already in there, why don't they just do the fundoplication? And once they hear about the side effects, and a lot of times now they just come in already read, they research traditional surgical repair and TIF, and they're like, I don't, I'd rather just do the TIF.
Right, wonderful. Another question, any concerns of poor motility? If not, then do you just omit manometry or barium motility study?
I'm not doing a lot of motility, just again, because it's kind of a partial wrap, not a full 360. I'm starting to do endo flip. I've done about 20, 25, so I'm still trying to work that in my, work out how I'm going to use that. Obviously, if there's any concerns for achalasia at all, then they get the traditional transnasal manometry just to rule that out. Again, in my 95, I've had one patient with dysphagia, just one, and he just had a stricture, which I think was just the natural part of his esophagitis healing. And I waited enough till I felt comfortable dilating, and dilated, and he's never called back.
Okay. Dr. Ihde, any?
Yeah, I have a similar experiences. We'll have patients, and I've been using EndoFlip as well. When we do a workup, we use the validated surveys to come to the diagnosis of esophagitis reflux disease. And then we'll do endoscopy, pH, and EndoFlip all at the same time. And that obviously is an advantage to the patient. They usually also will get a gastric emptying study and a hiatus scan separately. And then once you've been doing EndoFlip for a while, you realize that you can see some of the things that you otherwise see on manometry. Once you've done manometry for a while, you can look at some of those picture representations, the mobile representations. So yeah, I can see a band of pressure here. He may have some fibrosis there, or, and then so long as they're not showing issues with they have appropriate distensibility, then we'll go ahead and operate on those patients. If I feel like they might have a motility issue by looking at the contractions, then I'll send them for high resolution manometry for sure. After hiatal hernia TIF or after TIF, we do have some patients that have some dysphagia. We will repeat EGD pH to be sure that we're controlling reflux, do another EndoFlip, and you will see again like these bands of pressure. And then we'll use ESOFlip, which is kind of the partner device to EndoFlip, and do a dilation. And we've been fairly successful with dysphagia. And what we find is the dysphagia is a little bit higher up in the esophagus. It's not necessarily because of the fundoplication at all.
Great. Thank you. This question is for you, Dr. Ihde. Can you speak to the percentages of patients you see where the hiatus absolutely needs to be repaired prior to TIF versus just straight TIF?
Well, and I always preface the answer to that question in that because I'm a surgeon doing this, I see patients that that are a little bit further down the line. In other words, they've seen a gastroenterologist, they've been on maximal PPI therapy. The gastroenterologist is sure they have a hiatal hernia, so of course I'm going to find a hiatal hernia. So my patients are a little bit pre-selected, and so pretty much everybody I see, I would say 98% of them are going to have a hiatal hernia. I do get a lot of primary referrals and a lot of endoscopy. So I see people sometimes that have a normal looking hiatus, and we still, go to pH to be sure that they have reflux. I think Dr. Schneider probably sees the earlier end of that patient spectrum and maybe sees more patients that don't have a hiatal hernia.
Yeah, that's probably true. And I meant to point out during my talk that my time doing the upper endoscopy is probably increased fivefold, because I'm sure we've all done 60-second upper endoscopies and you retroflex, no hernia, no tumor, no ulcer done. But what I've started doing now that I've done TIF, and I've encouraged my partners to do when they send patients over, is to really spend a long time, insufflate, rotate the scope, kind of irritate the lesser curvature. And almost all the time, you'll see it open up, or the patient will take a deep breath or cough, and you're like, oh, thought they didn't have a hernia. There's a huge one.
Right. Okay, great. So do you feel like doing a TIF after a hiatal hernia repair is technically easier than a straight TIF? You both could answer that.
100% easier.
Yeah, I agree.
Okay.
Yeah.
Do you want to explain further or go in a little bit deep why you think that is, or?
I mean, for me, it's just and Dr. Ihde may be able to answer this better. For me, that it's just technically easier. When there's no hernia, it's been fully reduced below the diaphragm. The one I did this morning, after we took the device out, the nurse said that took 10 minutes. Oh. It's not because we were rushed, just because everything was perfect. But yeah, if you're pushing the limit in a Hill grade 1, Hill grade 2, 1 centimeter, 2 centimeter hernia, it just takes a little more time. That's maybe me being a little more cautious, but certainly I think they're quicker and easier, technically easier to do after the hernia repair.
Yeah, when I do the hiatal dissection, I take down the phrenoesophageal ligament, so it obviously creates more mobility to the G junction, and I think it just makes it easier that way.
Perfect, thank you. Dr. Schneider, did you have any pushback in gaining surgeon support for the combined procedure? My surgeons prefer to offer a Nissen.
Yeah, a little bit. I just kind of used the funnel analogy to the surgeon, saying, and the gateway analogy, saying we're at the top. You see, obviously, 1,200 different patients the past 2 years. And I didn't, push it on her. I just said, look, this is the data. It looks good. It looks safe. Patients are going to want this when they do online research for it versus the Nissen. And she said, we're just going to give it the trial. And honestly, I mean, I probably would have gone to a different surgeon if she said no, but I think she appropriately said, we'll give it a shot. And because it's worked exceedingly well, better than I ever expected. Like patients in my office crying, not because they're upset, but because they're not taking their PPIs anymore. Yeah, that we've continued to do it. And again, it's been a lot of extra cases for her the past couple of years.
Oh, great. So if the surgeon does paraesophageal hernia repair, would you consider doing gastropexy after TIF? Just making sure that's what.
Yeah, I don't think it's necessary, especially now with the device they have. You get a very uniform fundoplication. It's very durable. We went from using 20 fasteners to 30 fasteners. So now that thing is is really durable. They're, patchwork around it. It's a pretty well established technique at this time. It's the old saying, you don't want to be the first doctor to try something new, but you also don't want to be the last doctor to try something new.
Right, right. Okay, we've got a couple more questions. Chronic cough and other LPR symptoms have mixed published reviews when it comes to Nissen, etc. In your experience, how well does the TIF work on reflux-induced chronic cough?
You want to start, Dr. Ihde?
Yeah, well, I have a lot to say. So the problem with in the Nissen era was there was not a lot of standardization of a Nissen. There was not a lot of agreement about how to repair or how to do a HIDL repair or at what point to do a HIDL repair. All of those variables go into your outcomes. And so, part of writing this paper and part of the point that I was making the talk today is we're trying to standardize things as much as possible so that we get very reproducible results. When you look at the statistics for LPR, you have typical reflux, your LPR symptoms are due to reflux. Well, that's still 20% of the time when, you're going to have a miss. I do think that we have patients in which we do the full workup. Our pH study indicates that they have LPR occurring. But even then, there are other reasons people have cough. There are other reasons why people have sore throats. There are other reasons why people get sinus infections. So it's never going to be as good as, treating people with the typical symptoms. It's always going to be a little bit off because you're going to miss some patients that you're just not going to get the cough to resolve. And then the other part is LPR takes about a year really for the inflammatory changes to improve. So although their heartburn and regurgitation might be better the next day, that's not going to be the case for the hoarseness and the cough and the clearing of the throat.
Dr. Schneider?
Yeah, I agree. Just what Dr. Ihde said at the very end, it has taken some time from a patient with LPR. I just saw a lady in follow-up. He was still coughing initially at a month, but it's completely resolved. So it just took time. And I feel like a lot of the referrals from the pulmonologist for dry cough, they've ruled out X, Y, and Z. And we feel pretty comfortable knowing that in their pH study that we're very likely to help them if we do an anti-reflux procedure.
Okay, 2 more questions. What if the surgeon does both hiatal hernia and the TIF? I guess that refers to the partnership. Do you like you said, you partnered with Dr. Trudy Goers, so and you would have gone to a different surgeon had she had not agreed. How would you handle? You don't have anyone right now in your practice that does both, or at your hospital, if you will.
There's no surgeon that does the TIF procedure, but I wouldn't if she kind of learned to do the TIF. I don't think it'd be a big problem. I think I'd still be involved in the patient's care, maybe with another surgeon. But I think still with Dr. Goers, of all the patients I would be referring her, I'd obviously prefer if God was the one doing the TIF.
Perfect, thank you. Dr. Ihde,
for surgeons, what you got to realize is there's so many people out there with reflux that you're never going to run out of referrals. And having a partner and a gastroenterologist do the workup, well, that just makes it easy for me as a surgeon. I think in my setting, in a rural setting where we don't have a gastroenterologist, it's great for the surgeon to do both. We certainly can do it. I came from a metropolitan area down Dallas, so I've been in both environments. There's plenty to go around when you're talking about reflux, and that is the last thing that should be a battlefield between gastroenterologists and surgeons. It just doesn't exist.
That's well said, Dr. Ihde. Thank you. We have another question for you, Dr. Ihde. Can you please explain where fasteners 21 to 30 are placed typically in your practice?
So my typical application is I usually go to 1 o'clock corner and I'll put 3 sets of 2 fasteners, and that'll pin that corner, and then I rotate around to the 1 o'clock corner and I'll put 3 sets of 2 there. And then I do 2 each at the 5, 6, 7, and 8 o'clock position at about 3 to 4 centimeters deep. And at that point, I reload a cartridge and I'll go back in. I'll put 2 more at 1 o'clock, 2 more at 5, 6, and 7 o'clock, and then 2 more at 11 o'clock. And then I'll look and see, you know, does this look uniform? Do I have a double row of fasteners circumferentially around the fundoplication? And if I do, I'm happy and I stop. I feel like there's a loose corner. If I didn't get that corner pinned up well enough, then I'll reposition the helical and I'll try and pull that tissue up a little bit more and try to pull it up. I think there are cases certainly in which you could do what looks like a 360-degree fundoplication, but I'm not sure that that's an advantage. I know there are a couple of surgeons that I've had discussions with where, you know, they try to get as much as possible, but they've also admitted that maybe they have a little bit more dysphagia after. Maybe better is not as good enough.
Do you want to comment on that, Dr. Schneider, in regards to fasteners?
Yeah, I guess the easy answer is that I just put them where they need to go. You know, after the initial, I do the 3 and the 3, and it's more, you know, my second 50, I've been more, it's almost more art than science, kind of looking at it and be like, nope, need a little more depth here and a little more wrap here. So yeah, my threshold has lowered grabbing another cartridge and doing some more, because more, I mean, it just makes sense. More is better.
Perfect. Thank you. Couple more questions. They keep coming in. I hope you guys don't mind. Dr. Schneider, this one's for you. How do you and your surgeon split payment for hiatal hernia TIF?
Well, we submit the same code, so we're getting the same RVU amount for that.
Okay.
So yeah, I'm pure productivity, so it's an RVU versus the conversion factor. I'm not sure what hers is, but yes, same RVUs for both.
Perfect. Yeah, just so all of the viewers know, in the chat box, Craig Gonzalez, who's our senior director of reimbursement, so he put the code in there. It's 43281 is roughly about $1,600 national average. With the 62 modifier, it's 62.5% per provider, just in case anyone was wondering that. And one last question, what percentage of your TIF only cases have been Medicare patients?
Oof, that's a good one. I mean, probably 2/3, I would guess. Yeah, well, I'll see prior authorization and get approved for any commercial.
We don't see TIF alone patients.
I'm sorry, you cut out a little bit. You don't see too many.
Yeah, we don't see too many TIF only patients. So I think maybe the few that I've seen have been Medicare, and you know, Medicare's already approved TIF alone, so it's not an issue at all.
Wonderful. Well, I can't thank you both enough for being here tonight and doing this TIF talk with us. I know there's a lot of good information you've provided to our viewers tonight, and I did want to give you an opportunity to both, I'll start with you, Dr. Schneider, if there's anything else you wanted to add about TIF, about your GERD program, any successes or anything that you would recommend to our viewers that are watching today.
Yeah, I mean, I guess like any newer technology, or at least new to me, there's some concern about its efficacy. So that's why I said, well, we'll give it a shot. This looks good. And when people have approached me saying, is it worth doing? Is it helping patients? I mean, like I said earlier, it's far exceeded my expectations. Again, I can't tell you how many number of people, ladies have been crying in my office. And usually when I walk in my office, they're crying. I know it's going to be a long visit, but they're crying because they can, like, flat at night, they don't take a PPI. So I've loved doing the procedure. I think we're really helping people. It's very safe, not seeing long-term side effects at all. My partners want me to do a TIF now instead of a surgeon doing a Nissen because they're not dealing with bloating complaints afterwards.
That's great.
Yeah, I highly recommend it.
Fantastic. Thank you, Dr. Schneider. Dr. Ihde?
No, just to echo what Dr. Schneider says, this has really been a procedure that has helped patients. Like he says, the number one complaint we get is they can't sleep at night. They're chronically fatigued, and it's driving them crazy. And so, the first thing you'll hear when they come back is, I've finally been able to sleep flat. And, it's a significant improvement in safety profile. It's a significant improvement in side effect profile. And I really believe that there's anti-reflux surgery.
Wonderful. I do have one last question for you, Dr. Ihde. You've been doing TIF for a very long time now, and you obviously wrote the paper on the evolution of the TIF procedure. But that makes me curious, are you seeing in all the years that you've been doing TIF or working on GERD patients, are you seeing any evolution in GERD patients?
Well, I've talked to a lot of primary care that ask me the question, why is there so much more reflux out there? And I think obesity has something to do with it. I think our consumption of soda has something to do with it because the overexpansion of the stomach, and I think maybe that injures the angle of His. I think that sort of the next step is our understanding of the hiatus. How do people develop a hiatal hernia? What's the structure behind that? When I dissect it out, I see that the musculature is not in its normal orientation. In other words, you don't have the crural slings where they should be. It's kind of an empty space that's covered by the front of a ligament. And I think those are the things that we are going to be looking at in the future.
Wonderful. Well, I can't thank you both enough for being here tonight and joining us for this TIF talk. I think you provided us with some really great information. I do want to say for all of those of you watching, there is another event. AFS has an event, 5 p.m. Pacific time, 7 p.m. Central time, 8 p.m. Eastern time. They'll be going over the detection of dysplastic Barrett's esophagus, presented by Dr. Mike Smith, Buckley, and Dan Lister. So if you haven't had enough of a webinar, please feel free to join their webinar coming up soon too. So again, Dr. Ihde, Dr. Schneider, thank you for being here tonight. And thank you everybody for joining us on our TIF Talk Physician Edition. Everybody stay safe and we'll catch you next time. Thank you.
Thanks, Andrea.
Thank you.